1, 2, 3 malocclusions and how to correct them and all that?
Surgically, yeah.
Surgically? Yeah, this is surgery, so I wonder if she's talking about it. I wasn't there.
Yeah.
So I need to know if she's covered it so we can talk about it. So, what's a class 1 malocclusion as opposed to a class 1 occlusion? Class 1 occlusion is where you expect the maxillary first molar mesial cusp to fit into the central groove of the mandibular first molar, right? So it means the upper one is just slightly behind and locks into it. And then the anterior occlusion, the incisors have a 2 millimeter over bite and a 1 millimeter over jet. Some people have 2, and nobody's picky about it, but the thing is the relationship between the upper incisors and the lower incisors is the lower incisors are inside and back so that there's over bite and over jet, right? A class 1 malocclusion means there's some aberration of those things. So even if the first molars are in the right place, if the upper anterior teeth are sticking up like this, it's still a class 1, but it's a malocclusion now, right? So you have to correct the malocclusion part of it. Class 2, what's the difference in class 2? Which jaw is in excess in the class 2? The maxilla? Are you sure?
Yes.
Class 2?
Suppose the mandible is too small.
It's also class 2.
Exactly. So you can have maxillary excess or mandibular deficiency. Either way, the relationship between the upper anterior teeth and the lower anterior teeth is this relationship, where the lowers are back here somewhere. So either these are too far out or these are too far in, but either way, that over jet is huge, with the maxilla being the larger of the two. So you have a class 2 malocclusion. So it may be the result of either maxillary excess, mandibular deficiency, or both, right? What about class 3? Which one? The answer to the question is not mandible. What's the answer to the question? Mandibular excess. Okay, so the mandible is usually really big, way bigger, and extrudes beyond where it is, or the maxilla is very small. Usually, when you say class 3 malocclusion, they expect you to have the mandible bigger and in excess, so that there's an underbite. Now, the upper teeth are behind the lower teeth, and there's an underbite. So you have to know which one is which and how to correct them. So you've got class 1, 2, and 3. Class 1 malocclusions are corrected by correcting the one thing that is out of whack, because it's a class 1 relationship of the skulls, but the teeth may be out the side, maybe extruded, maybe pointing out front. Something is wrong, but the relationship between the jaws is correct. So a lot of class 1s can be corrected with braces, just correcting the way the teeth are in relationship to each other. Whereas class 2 is corrected by what surgery? Class 2.
You get a Laporte.
And move it where?
Depends on which one.
Backward.
And move it where? Typically, your class 2 malocclusion is going to be your lower jaw is too far back and up inside the maxilla, so you want to move the lower jaw forward. Typically, 99% of them will not ask you anything other than you have it to reposition the lower jaw anteriorly to match this, what you call the class 1 relationship. So you're gonna move the lower jaw forward. What's the surgery, typical surgery for moving the lower jaw forward? osteotomy.
BSSO.
The BSSO, right? Why is that? Because the BSSO allows you to split the mandible this way and move it anteriorly. The difference between that and other surgery we're gonna talk about is that the BSSO, this bilateral sagittal split, sagittal means to split the mandible in half this way and slide it. It can be used to slide it back, but not typically. Slide it forward, because when you split the mandible and slide it forward, the bone stays in contact with bone as you slide it forward. So you can fixate it anywhere along the length of that slide, right? Now, let's say you try to fix it with a different type of surgery. So the other type of surgery would be to split the ramus vertically. So the vertical ramus osteotomy can also move the mandible forward, but you have to know the difference between the two surgeries and when you use which one. Got it? So the vertical ramus osteotomy, the ramus is split vertically, straight down from the notch to the inferior border at the angle. So it is a more useful surgery for pushing the mandible back than it is for sliding the mandible forward. Because it's this motion, right? So if you were trying to move the mandible forward and you use the vertical ramus osteotomy and did this, you'd create a gap. Whereas if you did the BSSO and slid it forward, the bone stays in contact. You understand the difference between this and this? So this is not used typically to correct the class 2. So you don't use the vertical ramus osteotomy to correct the class 2. Use it to correct the class 3, because if you split the ramus, you can move it this way. Now look, it's still in contact as you move it back, right? Moving it back. So the vertical ramus osteotomy is more useful for correcting the class 3, which is out here, and moving it backward, than it is for trying to move the mandible forward. Move the mandible forward better with the BSSO, which slides this way. And so the slide, you can, all the way along that slide, you can fixate it. And so you can move it for long distances forward. Everybody got quiet. Everybody understand what I'm saying?
Not the second part.
Oh, raise your hand. Okay, talk to me. What do you want to
So I don't understand the BSSO.
BSSO, let me see what happens. Luther. Okay. Everybody see Luther? Right. I don't know if they can get Luther's jaws to unpin in. He's stuck together here. So, he probably won't. So, just imagine that Luther's lower jaw is smaller than his upper jaw. So it's back here somewhere, right? I want to move it forward into this occlusion here. The best way to do that, to move it from a class 2 to a class 1, is the bilateral sagittal split. Sagittal split is done like this. See this line here? I'm drawing it for you. See that?
Mm-hmm.
The other side. Same thing, we're gonna do the same thing here. We're gonna draw this line down here. We're gonna take a saw and cut through half the mandible on that line, right? Then we're gonna go inside, bring it across, and then cut on the inside, down on this line where I'm showing on the inside here. And then you put an instrument in there and crack it in half. So now this ramus cracks away at this line, and the mandible can slide forward.
Okay.
Got it?
Got it.
Right. As opposed to the vertical ramus osteotomy, which is done with this cut right here, this one. Okay, so now this cuts all the way through the mandible from outside to inside. It leaves the condyle and the posterior border intact. And the rest of the mandible can move. But it is better now to move the class 3 backward with this one, because I can take this piece that I just cut here, bring it out to the side, and slide the mandible back into it, and lay this cut piece on top of it. So there's bone-on-bone contact when I slide it back.
It doesn't have to
But
be
if I
flat.
try to slide it forward, it would leave a gap between this one and this one. Right? See those two dots? If I slid the mandible forward, those two dots will come apart, right? There wouldn't be any bone-to-bone contact. So the class 3 is corrected most typically by the vertical ramus osteotomy, vertical ramus, sliding the mandible back. The class 2 is corrected by the split osteotomy, where you split the mandible in half this way and slide the mandible forward. That better?
Yes, thank you.
Okay. Somebody mentioned the Lefort. What would I do with the Lefort 1 osteotomy? The Lefort 1, what are the fracture lines of the Lefort 1? It's the same lines as the osteotomy. Lefort 1 fracture, right? Fractures through the piriform rib, right? Goes horizontally back underneath the zygomatic strut. I don't know if the people in the back can see that, but yeah, you're far away. Under the zygomatic strut, this is the zygomatic strut, and runs backward through the tuberosity and backward to where the pterygoid plates connect in the back of the maxilla, right here. So the Lefort 1 fracture takes this part of the maxilla, breaks it off at this line right here, all the way across through the piriform rib, through the pterygoid plates, and this bottom part becomes free, right? And that's called a horizontal fracture of the maxilla, or Lefort 1. So if I'm gonna use a Lefort 1 to correct anything, what am I gonna correct with it? I can free this part of the maxilla up, teeth and everything in it, right? What can I correct with that?
Class 3.
You can correct the class 3. If the mandible is where it's supposed to be, but it's still up front, and the maxilla is far back, you can do the class 1, cut it free of the skull, and move it forward. What else can you correct? You can correct the cant. If the maxilla is slanted, one way or another, you can correct. When you free the maxilla up, you cut the side that's too tall and level it out. You can move it forward. You can move it posteriorly. You can cant it from side to side. So the Lefort 1 osteotomy is a very useful osteotomy to correct various things. It just depends on what the relationship is between the maxilla and the mandible. So if you're trying to correct the mandible, you gotta fix the mandible with a vertical ramus or split. If you're trying to correct the maxillary position, you can move the maxilla with the Lefort 1, right? Okay. What are the lines of the fracture of the Lefort 2? It's called a pyramidal fracture. You're right. What makes it a pyramid? It takes this connection here, right? These are nasal bones right here, correct? The nasal bones connect to the frontal bone here, so this is a nasofrontal junction. Now, what makes it a pyramid? It fractures down through the orbit to the zygomatical maxillary suture line, which is this one in the front here, right? And then it runs backward, the same places that the Lefort 1 went. So now it looks like it starts here and runs down like a pyramid through the rest of the face. So that's why it's called a pyramidal fracture. Everybody got that? Started nasofrontal, separates the zygomatical maxillary, goes underneath the zygoma, runs backward through the tuberosity to the pterygoid base. So it looks like a pyramid. That's a Lefort 2. Lefort 3 is which one? Called the transverse fracture, right? Or what? What's the other name for it? Craniofacial disjunction. Craniofacial disjunction. The transverse now is going to separate the zygomatical frontal suture lines. These boys right here and here, and the nasal frontal and the nasal ethmoid and the orbit. Nasofrontal, nasoethmoid, nasofrontal, zygomatical frontal. So this is a fracture now. Let's cross this way. And I can take the whole face, the whole, not the mandible, but I can take the whole face and move it around. That's why it's called craniofacial disjunction. It breaks the face away from the skull through these fracture lines. Here, 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 and inside of the nasoethmoid, the whole face becomes free. What are the pathognomonic signs of the Lefort 3 fracture? Cerebrospinal rhinorrhea. Why? Because when you fracture through the nasal ethmoid, behind the nasofrontal and nasal ethmoid, what passes through the nasal ethmoid plate? The ethmoid plate, what goes through the ethmoid plate? There are holes in it, right? What goes through those holes?
Cavernous sinus.
Hmm?
Cavernous sinus.
Nope.
Cerebral sinus.
Cranial nerve. Cranial nerve.
Is it the deuce? Or you talking about the deuce? 3, 4, 5, 6.
Ethmoid. Comes down to the ethmoid. Olfactory, of course it does. The branches of the olfactory nerve go through the holes in the ethmoid plate, come down into the nasal cavity, so the superstructure of the nasal cavity, and the upper what do you call it? Help me, my brain is fried today. What are those bones in the nose called? Was no? Turbinates. There you go. So there you go. So above the superior turbinate, then all of those little fibers that come down through the place in the ethmoid are olfactory nerves, so you can smell. If you break that off, the olfactory nerves get torn. The holes are still there, but the holes are in contact with the cerebrospinal fluid that surrounds the brain. So it starts to leak into the nasal cavity. And you have cerebrospinal rhinorrhea. How do you determine CSF rhinorrhea? Test it for? Test it for sugar. Because snot doesn't have sugar in it. Cerebrospinal fluid does. So mucus running up the nose is not CSF unless it has the same glucose content as your blood supply. So that is the pathognomonic, and the word that you see on the boards over and over again is the pathognomonic sign for a Lefort 3 fracture is cerebrospinal rhinorrhea. So you've got Lefort 1, Lefort 2, Lefort 3. The pathognomonic sign of Lefort 1 is the malocclusion because the maxilla is floating across this horizontal level, not the transverse, but the horizontal. So the maxilla does this. The patient has a malocclusion, anterior open bite. If they get hit this way and it gets pushed up, they have an anterior open bite. All of those are pathognomonic signs. So if the mandible is not fractured and the patient has an open bite, chances are he has a Lefort 1 fracture. So that's 1, 2, and 3, right? And then you've got sagittal split, vertical ramus osteotomy, so you can fix a class 1, class 2, class 3. You can diagnose a class 1, class 2, class 3, and you can repair them all in the same way with fixation, screws and plates in the same way. What are the so principles of repair of fractures. What are the principles? What's the first thing you have to do with a fracture?
Stabilize it. Stabilize it.
Okay.
Fixation?
Which one?
Fixation.
No, first one. Reduction.
And fixation.
Reduction is the act of bringing the broken pieces together. Fixation is the act of keeping it there. And immobilization is the act of attaching it to everything else that it's supposed to be attached to. Because you can reduce and fixate a mandible and still not have it attached to anything until you fixate, immobilize it by fixating it to the maxilla and making it one big complex, right? So you got a reduction, a fixation, and an immobilization of the segments, all three. And then you have to prevent infection and do what? Correct malocclusion. One principle that the other specialties do not do. They do not have. So, the case we did today in OR, I was wanting to show you that, that's why I was trying to get those slides up there. He came in right here, and he said, were your teeth like this before? He said, and he had been broken at least 4 weeks. He healed in that position, and then he's out of here. So today is why we were in OR all day. We had to break his jaw again. We would take his wisdom teeth out, and that kept it jacked open. Then we had to bring him up to where we could. Then we had to cut both sides of his face open and break his jaw again. And once we broke his jaw again, we put these teeth back where they belong. First and foremost, that's the occlusion. We put his occlusion back together. And then we put plates and screws in the part that was broken in the back. That where the ramus was, we connected the ramus back to the body after we put him in the room. The ENT would have done that. They would have fixed the bones right where they were and left it like that so he could get it. Right? No. So you break, we broke it, put his occlusion back together, so he'll be a happy man when he makes her realize his teeth are back where they used to be. In a class 1 occlusion, he had a class 1 occlusion. So the principles: reduction, fixation, immobilization, prevention of infection, restoration of occlusion. Good. I think I had it here. Put your passport back here. I think this one has a shadow. That's you, I believe. Okay. All right, so I'm looking at old questions and see what we got. Class 2 malocclusions. Who lectured on cephalometrics? Cephalograms?
Dr. Harris.
SNA, SNB, all those angles? somebody mentioned that somewhere?
Like,
Or
In ortho? Y'all did not hear it yet?
Like 2 minutes. I'll say no.
Again,
I have
yes.
a question. Since we were talking about principles of factors and stuff, I was kind of confused on horizontal favorable versus horizontal unfavorable.
I'm gonna get to that.
Okay.
I'm gonna get to that. It's crying out there. The calisthenics and stuff, switch it out. Okay. So, when you take a lateral step on somebody, what landmarks are you looking at? Forget ortho, because all those, I don't care what all those orthos landmarks are. What do we wanna see? What are we looking for? Mainly, we're looking for about 4 to 5 major landmarks on a lateral set, right? S, which is S? Cella. N, Nasion, and then A is the deepest portion of the anterior maxilla, and B is the deepest depression on the anterior mandible, right? So the angle SNA is SNA, and the other angle is SNB. The difference between those two and what we're interested in surgery, we really don't care about all the rest of them. SNA is the relationship of the skull base to the maxilla. SNB is the relationship of the skull base to the mandible, right? So the angle ANB, if you look at the Ceph, forget S now, SNA and SNB, you're looking at the Ceph, the angle A and B tells you whether that relationship is a class 1, 2, or 3, right? Because if the mandible is ahead of the maxilla, then the A and B angle is negative. The negative A and B angle is gonna give you a class 3 malocclusion, and it means the mandible is ahead of the maxilla. So it should normally be what? It should be about +2, about 2 or 3. Nobody cares whether it's we're not that nitpicky, but you have to know that in the positive sense, that's where it's supposed to be. Now, if that angle is 8 or 9, then the maxilla is way out of whack, and you have a different class. Maxilla's up yonder. That's a class 2 relationship now, with respect to S and A. And then S and B is back here somewhere. So that positive number is too big. You've got a massive class 2. If it's negative in that way, it's a massive class 3. So a negative A and B, 5, 6, 7 degrees means the patient has a class 3 malocclusion. Everybody understand that? It's as simple as that. We don't really care what the rest of all the points and stuff. That's the only thing you see on our tests is what's SNA and A and B, that relationship in there. Okay. Now, I have, I'm sorry, we've got to figure out a way to get some clinical stuff done. These connections are really, really bad. Is this thing moving? If I fall, it's still pick me up. I won't be able to get up off that. That's somebody making me. All right. So, if I look at the mandible from an inferior or superior view, right? It's called the vertical view, so I'm looking at it this way or this way. What you have to look for, and I have them in here, it's just hard to see. Anyway, what you're looking for is a fracture of the mandible and the direction that the fracture line runs when you look at it vertically. So if you're looking at it from the view you're looking at it right now, and the fracture lines run opposite to where the muscle attachments are, how does that run? What's on this, what's connected to this ridge here? The mylohyoid, both sides, right? It's like a platform under the tongue, it's a floor of the mouth. So when the mylohyoid contracts, it pulls this way. If it can pull the fracture segment toward it, and it can displace toward it, it is a vertically unfavorable fracture. If the fracture line runs the opposite direction, we'll have some more slides with this, but the clinical ones are more dramatic when you look at them. If the fracture line runs from out to in, but in a backward direction, and the mandible cannot be pulled in with the mylohyoid, then it's a vertically favorable fracture. Got it? The most important times that you will see that is if you have a symphyseal fracture, like one in the middle, and then you have a body or angle fracture, so these two segments are free, and the muscles are free to do whatever. If the two segments can get snatched into the middle, then they're unfavorable vertically. You can have one vertical on one side, one favorable on one side, or unfavorable on the other. Everything depends on the fracture line. Now, when you look at it from a horizontal point of view, this view right here, the fracture line depends. I'm gonna draw it so everybody can see it now. See that line? Let's say you have an angle fracture that runs that way. What is the muscle pull on the proximal segment? This is proximal, this is distal. On the proximal segment, what's attached to the proximal segment? Masseter. Masseter is attached here, yes. What else? Medial pterygoid is attached on the other side. This is not a sling here. Then what's attached here?
Lateral pterygoid?
Hmm?
Temporalis?
No. What's attached here?
Lateral pterygoid.
Temporalis muscle is attached here. This is the choroid process, this is temporalis. So on this little piece of bone right here, you have the three biggest muscles of mastication. Temporalis is pulling that way, because it's attached up here, right? And then the masseter is attached here, and it's pulling that way. And the medial pterygoid is attached to the pterygoids here, it's pulling that way. Everything is pulling out. And your fracture line is this way. Can this displace?
Yes.
You said your fracture line is which way?
The one I drew right here.
Yeah. Yeah, you can pull it up, right?
This can pull up, pull forward, right? So it's horizontally unfavorable.
Okay, I'm gonna get that one.
Questions?
Can you do that one more time? On that back.
Can everybody see the line that I drew?
Yeah.
Right. So if I break this, and this patient comes in with this fracture line, this bone here is going to be kicked up in this way because the temporalis is pulling this way, the masseter is pulling that way, the pterygoid is pulling that way, this whole bone is going to displace. It can be displaced because there's nothing holding it down, right? So looking at it horizontally, it's a horizontally unfavorable fracture. Let's go to the other side. Let's draw this up, this fracture line here. Everybody see that one? What's the difference now? This lip of bone here is being held down by this now, right? So it can't flick up. And it can't be displaced by the same three muscles on this side because the fracture line is opposite direction now. This is a horizontally favorable fracture.
But that would be vertical.
Everybody got that? Horizontally favorable, unfavorable, vertically favorable, unfavorable. Everything depends on the muscle pull. So most of the questions that you'll see, especially on boards, will be related to which muscles are pulling and what direction they can pull. So temporalis is always up and anterior, and so if it can move, it'll move up and anterior, because that's the biggest muscle here. It's attached to the whole side of the skull, and then pull that whole fragment right up like this.
Can you give us another one?
Another example?
Another example question?
There's not many more. Most of the fractions that you will displace are going to be displaced this way. If they're going to displace vertically, it's displacing this way, and it's usually mylohyoid, because they're pulling from side to side. So you're looking at it from where these fracture lines are viewed at the vertical side. So nobody's gonna make it too complicated to you can put this line anywhere, it's still gonna be a favorable fracture, because it has a lift to hold it down. Whereas this side does not, it'll kick right up. Got it? Got it. Hey, station. Yeah, password. I'm trying to keep it out this time. All right, let's see. Dentofacial deformities. What causes dentofacial deformities? All those things we were talking about. All the class 1s and 2s, and what causes them?
Development, trauma,
The number one cause of ugly is genetics.
Got it.
Granted. Okay? That's not the only thing, because prenatal care can cause it, especially if that prenatal care causes a lapse in the development of the fetus at some point because of some nutritional imbalance that the mother had. The reason that I am on the Tennessee pregnancy plan is because the OBGYNs just finally acknowledged that the low birth weight babies and the babies with twisted faces and all those things happen because the mothers are on drugs and they do all kinds of stuff and they don't eat right, and they have these term babies that weigh 2 pounds and stuff, and so they finally said, we'll sign off on whatever we need to do for the pregnant mothers to be treated. And so I get to hold my breath and soil my pants because I'm treating a 38 week pregnant female that I'm doing full mouth extractions on, which we never used to do. Now they come every week. I have at least 2 every Wednesday. And we have to take all their teeth out. Why? Because the OBs said, we'll sign off on it. And I keep telling them, as long as they don't have the babies in my chair, they're okay. I'm not baby daddy, papa, I don't pay no child support, myself, so do not have your baby in my chair. But I'll try to get your teeth out for you. And so, why is that? Because lapses in nutrition, use of drugs, all those things act on prenatal dentofacial deformities. But the number one cause of dentofacial deformities is genetics. So even though genetics and prenatal stuff and environmental influences and trauma, all those things can cause it, but the number one cause is genetics. When is the best time to do orthodontic surgery? When
After you establish the.
adolescent growth has stopped, or as close as possible. How do you determine whether adolescent growth is stopped or not? Hand wrist. Hand wrist x-rays to determine whether the epiphyses of the bones in the hand are closed. If they're still open, there's growth potential, then you try to delay orthodontic correction until those epiphyses are closed and you don't expect any growth. Now, the problem with that is, I think my son he was about 5'6" till he was 16, and he decided to run track. And he grew another 6 inches as soon as he started running track. So, we don't know why, but it stimulated the growth patterns, and he just grew another 6 inches. So you can't go exclusively by the hand wrist x-ray, because you don't know. The environment has a lot to do with it. So you gotta be able to put all that into perspective. Correct, let's see what the old questions had. Surgery to correct isolated mandibular excess. That's class 3 malocclusion, we talked about it. Oh, I missed one. Thought I forgot one. Okay, so there is a limit to the discrepancy between the maxilla and the mandibular measurements. There's a limit to which surgery will move what jaw. How do you decide what to do? You decide it based on the amount of movement that you need to correct the facial structures, facial relationships. So if you have a class 3 malocclusion, say, and the mandible is 15 millimeters ahead of the maxilla, chances are you're not gonna move the mandible back 15 millimeters. But you can move the maxilla forward some and the mandible back some, and the movements have to add up to the deficiency that you wanna correct. So if you have a 15 millimeter deficiency, you can move the maxilla forward 8 and the mandible back 7, and you will still have a total movement of 15, but the facial balance will be better than if you try to move the mandible back here and stick it in the patient's throat somewhere. That it is, they cuts off the air and they try to get the mandible back too far. So there's a limit to how much you can move, and the best thing for a large movement is to move both jaws, put them into a better relationship. So, but the movement, remember, has to add up to the deficiency when you finish. I just saw that on a board question now. Let's see. Pathognomonic signs for sequence of repair facial bones. Multiple facial fractures. Multiple facial fractures. How do you come up with a plan to fix multiple facial fractures? Your 9-year-old falls out the 3rd story window and lands on the sidewalk.
Go top down and bottom up.
Happens a lot, more than you would think. One of our assistants, this is about 7 or 8 years ago, left our children in somebody's care on the 3rd floor of a hotel downtown, and one of the kids opened a window that he shouldn't have, and one of the other little kids ran full tilt, launched out the window, landed on the sidewalk, and survived. What's the plan for repairing multiple facial fractures? How do you do it?
Top down, bottom up.
Hold that thought. Anybody got any plans up there?
See what you got, sir?
Yeah, you gotta
Know
see
what I
it.
got?
So, the plan to repair is first to repair each bone. Hence, whether it's favorable or unfavorable, you repair the bone. So if the mandible is broken, you try to repair the mandible, right? But then you have, the maxilla is fractured. What you gonna do with the mandible? Attach the mandible to the maxilla. The maxilla is fractured. You have to attach the maxilla to the zygomas. The zygomas are fractured. There's a zygomatical maxillary fracture. You gotta fix the zygomas to the frontal bone. That's called caudad to cephalad repair. Tail to head. Start at the bottom and work up. Can you work down? Yes, you can. Different type of fractures when you work it down. You work down, I usually have multiple skull fractures, as in frontal bone, people who hit the steering wheel, and they come in and the frontal bones are crushed into little bits. Then I have to peel the scalp down over the face, like that movie Face Off. We do it a lot. And we fix the frontal bone. And then we fix the frontal bone, we attach the zygomas to the frontal bone. Then we attach the maxillas to the zygomas, then we attach the mandible to the maxilla. So that's called cephalad to caudad. So it's head down or tail up, depending on what you're fixing. Did anybody talk about segmental osteotomy? Taking portions of the maxilla or the mandible and moving them around. None? Nobody?
Not ringing a bell.
Not ringing a bell? So if you have a patient who has a super erupted 2, 3, 4, let's say, do you just extract the teeth? Most people, this is what they opt to do, because the correct option is to move that segment with the teeth in it back up. And that's called a segmental osteotomy. So if your patient has a super erupted segment of teeth, if your patient closes and the whole upper 6 anterior teeth cover the lower ones all together, you can't even see the lower jaw, you have to move that segment up, right? Either that or extract all the teeth, but no, you don't have to do that. So you refer the patient over to ortho and oral surgery. Ortho will level the teeth out where they are. Oral surgery will take the segment, cut it away, trim off the top, move it up, and fixate it at a higher point. So that's the anterior 6. That's the segment. That's the anterior segment of the maxilla. I'm gonna move up or down. You know those people that smile and all you see is gums? We do those same segmental osteotomies to correct that gummy smile by cutting away that maxilla, trimming it, and moving it up. Get rid of some of the gummy smiles. So I wanted to make sure, because I saw 2 questions about segmental osteotomies. That's what they are, where you take a segment of the jaw and move it to correct something else. Super erupted teeth can be corrected. Gummy smile can be corrected. Same thing, except now you may have to bone graft the gap, because if you have an anterior open bite and you try to close it, I'm gonna break this segment and move it down here, but what am I gonna put in above it? So I will take some bone from the posterior of the mandible or from the patient's hip and put it like a sandwich in between that gap that I made, right? And then fixate it in there, so I put a bone graft in because I've moved that segment to close the anterior open bite. I did this, right? But I left a gap up there on the top. You can do it in the bottom, with lower anterior teeth, without having to do a graft, because you can cut the lower, anterior teeth into a segment and move it up. And just use some regular packed bone graft in the deficiency. So, but either way, the difference is, to move it up, you gotta trim it, but to move it down, you gotta put a bone graft in the spot. Everybody understand the difference? Ooh, let's see here. Let's see. Odontogenic infections. Infections. How do infections spread from fascial space to fascial space? That's one. But why from fascial space to fascial space? As I told you, the spaces are contiguous. Contiguous. So what allows the infection to go through those walls, those contiguous walls? What eats through the walls? Acid? Acid? Byproducts of infections are lower the pH to 7.2 or 3 instead of 7.7 or 8. That's number one. And when that happens, what's the acid that allows the bacteria to eat through the wall? Let me see who's read that. What acid? What acid?
Phosphoric
Nobody
acid.
read that chapter. How are you gonna do an exam you haven't read?
Phosphoric.
Huh?
That's a lot. We get it.
Phosphoric acid.
The enzyme is hyaluronidase. There you go. See, yeah, rang a bell there? So, the hyaluronic acid is cleaved by the enzyme, and it allows the low pH infection to eat through from space to space, eat its way through. So you got a combination of things. The spaces are touching each other, so that makes it easy. And then the acidity lowers the pH, and the hyaluronic acid, which usually helps to keep the membranes intact, is cleaved by the enzyme hyaluronidase. And once that breaks it down, everything goes right through the walls and it spreads into the next space. What are the principles of treatment of odontogenic infections? Come on. Incision and drainage. Why? Everybody say, because antibiotics do not evacuate pus. Do not. Antibiotics do not evacuate pus. So you have to create a place for the pus to go, or it'll find its own drain and come to the surface. But you gotta, incision and drainage is to get the pus out of there. That does several things. That allows the pH to go back up. It allows all that acid to stop working. And then the antibiotics can get to the area that they're needed. Because the antibiotics are what stop the growth of the new bacteria. They're either cytal or static. They'll either kill the bacteria or stop it from multiplying. So you need those two. And so after you've drained all the pus and given the patient antibiotics, what you gonna do?
Correct.
Remove the source. So you determine where the severity of the infection was causing it, you remove the source. There are sometimes, not much for me anymore, where you try to do the IND and send the patient home with antibiotics and bring them back later. I don't do that anymore. The antibiotics I have, I give them IV if I have to, but I'm taking the source out before the patient leaves. I don't want them to come back next week with the tooth and say, I feel much better now. I don't want my tooth out. So we try to remove the source as soon as possible. So you gotta do an IND, you gotta use antibiotics, you gotta take care of the source. What medical conditions affect the progress of odontogenic infections the most? What medical conditions affect the course of an odontogenic infection the most? Nobody?
What's the question one more time?
Huh?
What medical?
What medical
That
condition?
is a condition, no, we want that. Medical condition. Don't be shy. Throw it out there. It's common sense. You gotta throw it out there. So say it loud. Be proud. What you say? Ludwig, no, that's a result of the infection. Diabetes mellitus, number 1. Why? Diabetes mellitus increases the blood sugar level. The bacteria live on what? Sugar. So the higher the sugar, the more likely the infection is to take off and be out of control. So diabetes, number 1. Other thing is conditions which compromise the ability of the patient to fight back. So things that chemotherapy, which kills off the response of the patient to adverse bacteria. Chemotherapy kills it off. So patients who are, that's one of the things that happened during COVID. It took them a while to realize that people with compromised immune systems were dying in the thousands, millions really. But compromised meant people who had no ability to fight back. So chemotherapy was the number 1, radiation therapy. Anything that killed off the immune system, the immune cells, then anything that invaded took over. So if you had diabetes and you were getting treatment with chemotherapy and you got COVID, chances are you didn't make it. Okay? My sister died in 11 days because she had just gone through a course of chemo for breast cancer, and by the time that they realized what had happened, the COVID had taken in there, she had nothing to fight it with. 11 days from start to death, just like that. Chemotherapeutic agents, killing it off. What's the danger space? Space between the alar fascia and the prevertebral fascia. Why is it a danger space? Because it stretches from here all the way down into the chest wall. So infections which go through that, it go down into the chest wall, into the space of the lungs in days, and your patient's in deep trouble, because that infection is down in the top of the lungs, chest wall. So that's why it's called a danger space. It's one long space, connects everything on top with everything on bottom. Most of the others are contiguous and they have little pockets here and there, but the danger space is that because it has no a pathway from top to bottom. Somebody mentioned Ludwig's. What is Ludwig's angina? Bilateral. The key there is bilateral. So there's always 6 spaces in the Ludwig's. 3 spaces being nothing. So if it's all in here, it doesn't matter. Crosses the midline, you get submandibular, submental, and sublingual. It raises the tongue from the floor of the mouth, then you got a Ludwig's. What's the antibiotic of choice for Ludwig's? Empiric? What would empiric be? The difference there is, if the patient comes into the emergency room with a Ludwig's, you don't need empiric antibiotics. Empiric antibiotics you use them when you're not sure what to do, right? So a patient comes with a little knot on the side of his face, you need an empiric antibiotic, give some penicillin and it'll work or it won't, right? But if he comes in with a Ludwig's to the emergency room, he's gonna die in 24 hours if you don't give him something. Empiric is not gonna work. Antibiotic of choice. Clindamycin, there you go. Penetrates that tissue faster, bone faster. The Ludwig's tissue is like wood for the first 3 or 4 days. It's really hard. It doesn't even have any pus in it, just swollen and hard. But we put drains in there just to wait, and it takes 4 or 5 days before it starts to break down enough to produce pus. In the meantime, we've got the patients on everything we can. Everything we can. I had Ludwig's in my knee, I guess. I don't know. They had me on dueling antibiotics. My left arm had Unison, right arm had vancomycin. They were just alternating the 2, running them in for 6 days. That's all I had was the 2 antibiotics running into both of my arms. And now I'm on antibiotics for 6 weeks. Because they're determined to kill everything off. I know you have bad breath. They kill everything. Let's see. Treatment for Ludwig's? Adrian? Penrose drains. Well, where are you putting them?
4 extra ones.
You already said 6 spaces, so why are you gonna only drain 1 or 2? So you need to put drains in the Ludwig's. You're gonna have bilateral, submandibular, submental. Sometimes you can go through and through and put 1, but it's still two there and then 2 under the tongue for sublingual, right? Penrose drains, yes. What are you gonna do? What infection usually causes cavernous sinus thrombosis? There you go. I heard him, right? You heard one answer. Canine fossa is where it usually starts. How does it get to the cavernous sinus?
It's 2 ways. Superior and inferior.
2 ways? Say again?
Inferior vein, or
Canine space 2.
The alveolar.
the vein in the corner of the eye here? Oh. Not yet. Vein in the corner of the eye first.
Angular?
Angular. It's an angular vein. How does it get from the angular vein into the eye?
No, it's not the,
Ophthalmic vein. How does it get through the ophthalmic vein?
all right, you know it.
But, come on, B. Tell me, talk to me. How does it get back there? You've been right so far, come on, man. The angular vein and the ophthalmic veins have no valves. So you get retrograde flow back up into the eye, back up into the cavernous sinus. What's the pathognomonic sign of cavernous sinus thrombosis? Paralysis of the orbit. Does it affect the patient's vision? No. Right, because of which nerves?
3, 5, and 7.
3, 4, 5.
And 6. Those are the nerves that run through the cavernous sinus, and therefore when the infection hits the cavernous sinus and the pH goes down to 7.2, they stop transmitting. So the patient can't move their eye because those muscles stop working, right? Cavernous sinus. Infections which start in bone and usually from teeth, and then affect the cancellous bone. What are those infections called?
Infections that start in bone.
Osteomyelitis. How do you define osteomyelitis on a radiograph? What's the sequestrum?
It's like radio.
It's the dead bone in the middle of it.
Yeah, surrounded by
So,
involucral.
what's the dark space around the dead bone?
Involucral.
Involucrum.
Yeah.
Yeah, that one. I didn't follow you.
I would've got it right over
You
here.
heard me. You got it. Involucrum. What happens in the involucrum?
Okay, see.
There's no, it's not an empty space. It's a busy space.
Infection.
Nope. So you have two types of activity going on in the involucrum. And there you go. So bone is being broken down of the dead piece in the middle and deposited on the outside from healthy bone, right? So in order to treat osteomyelitis, you have to remove the sequestrum. Get the dead bone completely out of there, and so that the area can heal. As long as that dead bone's in there, your body's gonna try to keep on breaking it down and chewing on it. And that's where you said, what happens? You get a sinus tract, because the pressure builds up, the body's breaking it down, this fluid that's gotta get out of there, and you end up with the little sinus tracts draining it out. It's chronic drainage, chronic drainage. Dead bone in the middle of osteomyelitis. That covers most of the questions that I have. Let's go.
so silly, bro. I have not, yeah, but it's a very tiny lot. It's just the same. So you have to try. Oh, it's fine. For your phone? Yeah. My phone won't look like that. My phone won't look like that either. Mine's big.
There's some lectures that you missed.
Square.
I don't know what she's gonna do with those. Y'all gonna negotiate that with her. Something about the hospitalized patient, anybody talk about those? I saw it last year's schedule, that management of hospitalized patients, and that was right before TJ. Nobody understood yesterday that we had interviews all day, so that screwed yesterday. Do not forget medical emergencies. That is always fair game. We are interviewing people for residencies now, and at least there's 10 or 12 people asking questions on the Zoom calls, and at least 2 or 3 people say, so tell us about a medical emergency you treated. And people go, not good. Y'all gotta, who believe the stuff that you don't know, cause you don't care. But if you, those of you get ready to go on interviews now, be prepared to answer questions like that. Tell us about the medical emergency you treat. So if your patient loses consciousness, what do? So always maintain the chapters on medical emergencies, read them, be up to date, especially with simple things like syncope and, just always be sharp. All right, y'all have any questions? We're going down through here, the rest is lectures you haven't had yet, that I haven't given anyway, so. We're gonna catch up on those. Hopefully start next week. Most of this is infections and EMJ and pain management. Fractures, mandible fractures, questions? None? Good, can I go home then? Thank you.